begin. So thank you very much, everyone, for joining us today for our Hashir International Institute Lunchbreak Webinar on misophonia research and recovery. My name is Rebecca, and I'm a patient support officer at Hashir International Institute. And today I am joined by Mercedes Afanian. Mercedes is a neuroscientist and one of the most active researchers in the field of misophonia. In fact, her knowledge is so valuable in this area that when scientists created a definition of what misophonia is, Mercedes was one of the 15 global experts who contributed to the definition that we use today. So really significant knowledge and a fantastic opportunity to get her perspective on some of the latest understandings that we have about misophonia. So like I said at the beginning, we encourage everyone to leave comments and questions in the live chat, and we will discuss them after Mercedes' presentation. So over to you, Mercedes. What are we discussing today?
Yes, thank you everyone for joining us today. So today we're going to be talking about one of the recent studies published by our colleagues at Duke University. But before that, I need to give some basic information about the type of treatments that they used. So I try to share my screen and let me know if you can see my screen. Yeah, okay, cool. So at the end of today's session, we will have also some questions to answer. I'd like to again emphasize that these webinars are part of a monthly series organized by Hashir International Institute. We appreciate your continued engagement and encourage you to stay tuned for upcoming sessions where we will continue to explore various topics related to misophonia. Like I said, I would not need to talk about some basic science and basic explanation of the type of treatments that Duke University colleagues used in their study. Since the emergence of misophonia research, a few studies have proposed treatments for misophonia, a disorder that is characterized by reduced tolerance to specific sounds or stimuli associated with those sounds. So the type of, when we generally talk about psychiatric disorders or psychological problems, we consider two main types of treatments and how they affect the brain. It is important to first understand that there are various types of treatments, treatment strategies or methods that basically try to or aim at modifying behaviors, feelings, emotion, attitudes, thoughts, or even physiological responses that we do not have that much of a control upon. However, it really depends on what type of issue or disorder you're talking about. Some methods are more invasive, such as neurosurgery, like deep brain stimulation, in which the neurosurgeon puts an electrode deep in the brain, or ECT, or electroconvulsive therapy. Some people know it as shock therapy, while other types of treatments or inventions are less invasive, like neurofeedback, medications, TMS, TES, and psychotherapy, among all others. TMS stands for transcranial magnetic stimulation, and TES stands for transcranial electric stimulation, that I will talk about in this presentation. Some of these treatments are bottom up and some others are top down. rTMS is a type of TMS, or repetitive transcranial magnetic stimulation. It is considered a bottom up treatment. So by targeting a specific brain areas, it aims to modulate or change neural activity in those regions. On the other hand, CBT often incorporate top-down elements. This approach explores patterns of thoughts, emotions, and behaviors within the context of broader psychological elements or psychological frameworks. In particular, cognitive restructuring, which we will talk about today, in CBT involves identifying and challenging maladaptive thought patterns and beliefs at a higher cognitive level. In simpler terms, bottom-up treatments are the treatments that target the brain itself. So in result, when you change the brain or you modify the neural activity of the brain, it changes emotions, feelings, thoughts, cognition, and anything else that is manifested from the brain. On the other hand, top-down treatments are the treatments that target emotions, cognitions, feelings, thoughts, and change them to change the brain. So more about these two treatments that we are going to be talking about today, rTMS and cognitive restructuring. Repetitive transcranial magnetic stimulation, or rTMS, as I said, is a non-invasive procedure used to treat certain mental health conditions by stimulating specific areas of the brain using magnetic pulses. It is akin to using a powerful magnet to send small pulses of energy to particular parts of the brain. Here is how it operates. During rTMS, a coil that you see on the slide, the device basically, is placed against the scalp, typically on the forehead. However, it really depends which part of the brain the expert is targeting. And it generates magnetic pulses repeatedly, lasting for several minutes to an hour. These pulses penetrate the skull and reach the brain, where they can activate or inhibit the activation or activity of nerve cells in the targeted region. Think of it as gentle taps on the brain that can help regulate or alter the activity of brain cells. By stimulating or modulating brain activity, what we mean by modulating is changing and manipulating. The brain activity in this manner, rTMS, has shown effectiveness in treating conditions such as depression, anxiety, and many more. We have already talked about CBT in previous webinars, but I would like to also tap into real quick. So CBT is a form of psychotherapy that has proven effective for various issues, including depression, anxiety, substance abuse, relationship problems, eating disorders, or even way more severe mental illnesses. Numerous research studies indicate that CBT results in significant improvement in functionality and quality of life of sufferers. In many instances, CBT has been shown to be as effective as, or even in some cases, more effective than psychiatric medications. It is important to emphasize that advancements in CBT have resulted from a blend of research findings and practical applications in clinical settings. Unlike many other psychological treatments, CBT stands out as an approach supported by substantial scientific evidence demonstrating its effectiveness in promoting positive change. In CBT, various techniques are employed, including cognitive restructuring. So in simpler terms, there are four main steps in cognitive restructuring. The first step is becoming aware of our thinking process or our thoughts. So the process starts by making our automatic thoughts conscious. It means that we become our own teacher. We just look at what thoughts we have. We try to become more aware of what we think and what type of thoughts our brain generates. The second step would be to evaluate these thoughts. Basically, it's like categorizing different colors. You have a lot of marbles in different colors. Some of them are red, some of them are green, and you try to categorize them. Categorize all the greens together and all the reds together. So this is exactly what we do with our thoughts. All rational thoughts together, all positive thoughts together, and all irrational and negative thoughts together. So it's time to begin generating more rational thoughts. Once you evaluate or reevaluate all these thoughts, you become rational. Or in other words, you try to replace irrational, maladaptive, and negative thoughts with more rational, adaptive, and positive thoughts, which as a result would affect on our emotions, neurophysiological responses, and ultimately it would basically decrease our symptoms and increase the quality of life. So our colleagues at Duke University examined the effectiveness of rTMS and cognitive restructuring in people with misophonia and compared them with people suffering from emotion dysregulation who did not have misophonia. So you might ask, before actually, Rebecca, you asked this question, I would like to answer it. If one of your questions is regarding the groups of patients that they chose for this study, that why people with emotion regulation and why compare people with emotion regulation versus misophonia? The main reason why they chose people with emotion regulation is because we know people with misophonia also suffer from different degrees of emotion regulation, especially when they are exposed to misophonic sounds. That's why we might see people with misophonia have anger outbursts, or they become aggressive verbally and in some, and actually less frequently physically aggressive toward the source of the sound. That's why these two groups are similar in emotion dysregulation, and they meant to compare these two people and how these two people basically respond to these two treatments. So both groups of participants underwent cognitive restructuring and rTMS neurostimulation. In this study, the main targeted brain regions for rTMS were dorsolateral prefrontal cortex and medial prefrontal cortex that you can see on this slide. The red part is dorsolateral prefrontal cortex, and the yellow part, and the yellow color basically, is medial prefrontal cortex, which is connected to left insula. In other words, they inhibit the activation of medial prefrontal cortex because previous studies showed that people with misophonia seem to have overactivated medial prefrontal cortex, or hyper-connected medial prefrontal cortex to other parts of the brain, like amygdala, that we actually talk about in one of our previous webinars. And they also stimulated the activation of dorsolateral prefrontal cortex because previous studies by Medical Center of University of Amsterdam showed that when people with misophonia are asked to inhibit or asked to control their response, their dorsolateral prefrontal cortex seem to be underactivated. So they need to activate or stimulate this part so they can inhibit or put a stop into their unwanted emotions and unwanted, for example, anger outbursts. Does that make sense? Okay, cool. So why these two parts again? Why these two regions of the brain, since there are a lot of different brain regions? These regions have been shown to undergo changes in function in people with misophonia. Dorsolateral prefrontal cortex regulates working memory, planning, decision-making, feeling of threat-induced anxiety, social perspective taking, theory of mind means understanding people from their perspective, understanding their emotion, understanding the way they think, and so on, deductive reasoning, and effortful emotion regulation. Medial prefrontal cortex is also responsible for regulating evaluation of risk and implicit downregulation of emotion. So these two brain regions are known as emotion regulation network. Basically, they both help us together to down-regulate or to control our unwanted emotions. And when one of these two brain regions do not function normally, people might be driven by their emotions. For example, they might have anger outbursts. They might get angry very quick. They might be aggressive, or they might cry in some situations that the basically behavior is disproportional. The effectiveness of these two treatments, rTMS and cognitive restructuring, were tested while people were listening to 3 different categories of sounds. The first category was the common misophonic triggers such as chewing. The second one was globally aversive sounds, means majority of people, regardless of having misophonia or not, or regardless of their background, would find them unpleasant, like ambulance sirens. This is very particular for me because I actually hate ambulance sirens, especially in London. They're loud and obnoxious. And the third group was neutral sounds, like somebody's walking. The purpose was to reduce the stress while monitoring abnormal physiological responses, like increased heart rate or sweating. Symptoms were assessed through self-report, means by a questionnaire, and physiological measures, basically by all these fancy devices that are attached to fingertips or attached to different muscles on the chest that measures heart rate and so on. What they found, as previously stated, the study examined adults experiencing misophonia and compared them to a group of people facing challenges in controlling emotions. And I have to add that the second group, the people that had challenges in controlling their emotions, had different types of psychiatric conditions. That's why we call them transdiagnostic group of adults. Means they might have different psychiatric conditions, however, they have something in common, and that's emotion dysregulation. Some of them had phobia, some of them, for example, had depression, some had anxiety, but they all suffer from emotion dysregulation. Surprisingly, both groups showed similar physiological reactions, such as changes in heart rate and sweat glands, when exposed to misophonic and aversive sounds, respectively. In other words, misophonic people showed similar physiological responses when they were listening to common misophonic sounds, when they compared them to people with emotion dysregulation, when they were listening to aversive sounds. So physiological responses were the same. This indicates that techniques already employed to assist individuals in regulating their emotion, such as CBT and rTMS, may also be beneficial for those dealing with misophonia, because there is a long line of research about emotion dysregulation and what treatments are more effective and what treatments are less effective. And since they have this prior information, they knew that already rTMS and cognitive restructuring would work for people with emotion dysregulation. They were asking themselves if these two treatments also would work for people suffering from misophonia that also have emotion dysregulation. Individuals with misophonia exhibited heightened distress upon the exposure to trigger sounds, more than people with emotion regulation difficulties when they were listening to aversive sounds. So in other words, when they looked at the questionnaires or the perceptual responses that people showed on questionnaires, they found when people with misophonia listen to misophonic sounds, report their distress higher than people with emotion dysregulation when they were listening to aversive sounds. Does that make sense? Okay, cool. Interestingly, there was a difference between self-report distress and physiological responses in people with misophonia. In other words, their questionnaire results or outcome was not necessarily in line with their physiological responses. simply because their physiological responses were the same as other group or emotion dysregulation, but their distress was increased, as I said before. So this suggests that perceived distress might be a unique characteristic of misophonia, distinguishing it from other clinical conditions. So what I have explained so far happened before applying the treatments, before running rTMS and cognitive restructuring. Once they did, or actually participants, all the participants underwent both treatments, they also measured their responses. So post-treatments, they discovered that using a top-down approach or cognitive restructuring was much more effective according to both questionnaires and physiological measures. When people with misophonia underwent only rTMS on, for example, right dorsolateral prefrontal cortex, they reported feeling significantly less upset when exposed to misophonic sounds, as indicated by questionnaires. So undergoing rTMS only helped the perceptual responses that was reflected on questionnaire, but undergoing or taking cognitive restructuring help misophonic people to not only feel less distress, but also it helped to decrease their physiological responses. All in all, this study suggests that combining neurostimulation and cognitive restructuring could be a very helpful approach for treating misophonia. However, more research is needed to understand how long these effects would last and how to best use these treatments, which obviously warrant further investigation. In short, new research is uncovering that misophonia is similar to disorders involving difficulty controlling emotions. While both misophonia and emotion regulation disorders show similar physiological reactions to certain sounds, the way people feel about these sounds sets misophonia apart. The study suggests that a technique called cognitive restructuring, which is a part of CBT, works better than neurostimulation alone for managing misophonia symptoms based on what people report about how they feel. However, when neurostimulation is combined with cognitive restructuring, it improves both how people feel and their physiological reactions. But we still need more research to be sure about these results and to understand what happens in the long term. So to finish my talk, if you or a loved one is struggling with misophonia, clinicians and healthcare professionals extend their support at Hashir International Specialist Clinic. Hashir Clinic is dedicated to providing professional assistance to individuals dealing with misophonia, grounded in a wealth of clinical observation spanning over a decade. Additionally, Hashir Clinic invites your interest in exploring their CBT course. Feel free to reach out and let them guide you toward effective solution for misophonia. Thank you.
Fantastic. Wow, yeah, thank you so much, Mercedes. So get your questions in the live chat. I have, and I guess an initial question. So that was such a helpful kind of demonstration, I guess, of how the study was carried out with this device that participants were wearing, and they were measuring while being exposed to like one of the trigger sounds, like a misophonia trigger sounds. And it's really interesting to hear that did reduce the upset, and like you say, especially when combined with cognitive restructuring. So if we kind of focus on the benefits that did have, that the neurostimulation did have, how does that kind of translate, I guess, to like a patient's experience, to someone who has misophonia, who perhaps feels like, oh, that's really interesting, that could help. But obviously from the study and the image that you showed, it is quite a large kind of connected device. It's, you know, it's not something that you could kind of pull out of your handbag and wear at the dinner table, or like wear in a cinema or something. It's quite, it's obviously still a very maybe impractical scientific device. So I guess my question is there a way we can see that being used, you know, work kind of fitting into someone's everyday life who has misophonia and wants to use that neurostimulation as a treatment option? Is that even imaginable? Yeah, what's your kind of take on that?
Yeah, sure. So the repetitive TMS or repetitive TES are the devices that should be actually applied by experts. It's not something that we can use. It's not like Apple Watch or E4 that you can put on and just do and go about your daily business. Basically, you have to make an appointment with the expert, go to the hospital or a private clinic, and they would first evaluate how many sessions you would normally need based on the severity of the problem that you suffer from, and then they will prescribe N number or X number of sessions for you. So every time you have to go there and they have to apply it for you. It's like, for example, making an appointment to get fMRI scans or PET scan and stuff like that. So an expert should do it.
Okay, that's really interesting. And so it has a lasting effect after these sessions. How long do they know how long that kind of usually lasts for after receiving it?
Well, based on this study, they actually did the assessment right after application of rTMS as far as I am aware. That's why at the end of the paper, they mentioned that the long-term effect of rTMS and cognitive restructuring should be also studied. So they have to test whether or not people would still feel the same after 6 weeks, 6 months, and 1 year, which I believe is an or ongoing study by our colleagues at Duke University.
Yeah, no, that's like you said, there is still more studying to be done, but a really interesting, I guess, starting point from.
Sorry, I need to add, because this is actually important to exactly highlight
Yeah.
how our brain shapes or change shape and form. Well, we know that the human brain is like muscles, is like the muscles of our body. It takes time for the brain to change, especially if we conduct, if we undergo top-down treatments or top-down interventions, the time would be way longer than bottom-up. For example, if somebody is suffering from tic disorder, they would go get surgery, neurosurgery, and or as I actually mentioned, deep brain stimulation.
Yeah.
Once you activate the device, almost immediately most of the symptoms go away. But for CBT is different. For TMS, it could be different. It takes some times for the brain to change, because we know that the brain is neuroplastic, means it changes its shape all the time. So it takes some times. If it's, for example, through CBT, using different types of strategies like cognitive restructuring, normally it takes, as I mentioned in previous webinars, in average 66 days for our brain to change.
Wow.
Something around 18 to 225, and this was research. Depending on the age of the person, we know, for example, the brain of children are more plastic than the brain of adults.
Gosh, yeah. And I think the webinar that you mentioned, that you gave a very in-depth presentation on that, the ability of the brain to change. I think that was January. So if you go onto our YouTube channel and find that webinar, there's a fascinating kind of deep dive into that subject, or as much of a deep dive as you can make within 45 minutes of a webinar. Thank you, Mercedes. So another question I have here is, this one involves a different study that is connected to today's discussion. So it isn't a misophonia study, but in February this year, scientists in Canada assessed the effect of rTMS for the management of depression. They used the same methods that you've described, And the results, to give a very, very kind of like brief, summary, the results of their study suggested that people with a lower severity of depression and higher global cognition benefited more from rTMS. So it's interesting, I guess, to me to think about how that is relevant to people with misophonia who are thinking they might benefit from rTMS, but perhaps they do have depression or some degree of severity of depression. So I guess my question with that is, your perception on how those two things can influence each other. And if someone has misophonia and rTMS could help them, is that help affected by whether they have depression or not?
That's a good question. And the answer is, I don't know. This is something that needs to be, because I always try to build my answers based on the results that we have available. And we really don't know this.
Yeah.
First of all, actually, there is another question that we need to ask ourselves before answering this question.
Okay.
If people with depression are at higher risk of developing misophonia, or if people with misophonia are at higher risk of developing depression because of their misophonia.
Yeah. That's
the common philosophical question or dilemma, I have to say. It's about egg and chicken. Which one comes first? Yeah. So this is a very difficult question, I have to say.
Yeah.
And I think before talking about the efficacy of or effectiveness of our TMS on depression and misophonia, we have to ask which one comes first. Which, as far as I know, hasn't been answered throughout literature yet.
Yeah. I mean, I guess from my work speaking to patients who have misophonia specifically, that is actually something that comes up a lot, that chicken and egg of am I feeling my depression because of misophonia or vice versa? What's causing what? And yes, I mean, I'm not a neuroscientist, so they perhaps haven't expected as much of an insight, but I've also had to kind of say it's, we don't really have that information, but it is a really important question to
However, being devil's advocate, I would like to refer to one of our webinars in which we talked about a recent study by University of Sussex. If you remember, they were following a group of individuals from the age of 8 to 12 till adult, and they found out people that were diagnosed or at least exhibited the symptoms of depression and anxiety at early ages were at higher risk of developing misophonia later in life.
So
that might answer that question.
Yeah,
somehow.
It's definitely an interesting perspective to keep in mind, isn't it? And what they found. Fascinating. Yeah. Let me have a quick check of our YouTube comments. I don't think I saw any pop up. No, so please do. What we do with these live webinars is that we make sure that they're on YouTube, and any questions that I'll put in the comments or the chat afterwards, we like to address them in future webinars. Like we've said in the past, if there's a particular topic that you find fascinating, we'd love to hear about it in this world and kind of have a little discussion on it. So just what we'd like to tell you about now are some very exciting events that we have here at Hashir International Institute at the moment. It's not just Lunchbreak webinars. We also have this incredible art competition that's called Sound Off. Entries are now open in Sound Off. We are asking people to represent their hearing experience through a piece of artwork. And that might sound really broad, but we want to encourage anyone and everyone who has an experience with misophonia, hyperacusis, tinnitus, whether it's a personal experience or that of a loved one, or even an academic experience, if you're involved in studying or researching misophonia, hyperacusis, tinnitus. How does that look represented in a piece of art? And again, taking art very loosely. It could be a painting, a drawing, a photograph, mixed media, sculpture, film, audio. Our art competition Sound Off is asking for entries that explore that experience through a piece of art. We have some really powerful entries already, and so we encourage everyone to enter. We've got some wonderful judges lined up, both from the world of audiology and from the world of art, and they'll be combining to choose several entries from 3 different age categories that the competition is sorted into. And also the winners, their work will be displayed at the 7th International Conference for Hyperacusis and Misophonia, which is taking place in Warsaw in Poland. That is in September. But the closing date for entries into Sound Off is the 30th of May. So the winners will be displayed at that conference, which is an amazing event where scientists from all over the world come to share their work. So you can find information about Sound Off on our social media sites, on our website, in events. We'll also put a link to the entry form and to the information page in the description of this video if you're watching this after it's broadcast live. And we're so excited about all of the entries that we're getting. So please have a think about yourself and your experience and how you can represent that. Share it with those that you might be part of in a community who might also benefit from getting that experience down on paper and entering the art competition. One very final reminder here, as Mercedes kind of highlighted at the start, is that here at Hashir International, as well as these conversations, as well as webinars and art competitions, we provide expert treatment and assessment with our various specialists. We offer treatment plans for misophonia, for hyperacusis, and for tinnitus, and would love to speak to you and provide more details if that's something you are struggling with, you are interested in pursuing at the moment. So please send an email to us. Again, I'll put our contact details in the information of this video. Also, our website has all of the information, but we'd also love to chat to you about it so we can discuss how our specialist clinics can provide support for you. So I believe that is everything.
I'd like to add something before we wrap up. Yeah, so before each seminar, we try to summarize and review different articles and scientific work on misophonia, and we publish at Hashir International Clinic website. Please feel free to take a look and then follow our webinars that we will talk about those articles and those studies more in details. So our main aim for these webinars and also publishing these reviews of different papers is to educate people suffering from misophonia and also family members. So we want you to ask questions and we want you to come up with ideas. So that would help us a lot to direct our research objectives as well, and also fine-tune the services that we give at Hashir International Clinic. Thank you.
Thank you very much, Mercedes. We actually do have one question that has just come up. So the question is, are there any side effects for rTMS? And do people use it for those under 18?
For misophonia, obviously, we don't know. But for other treatments, as far as I am aware, it's like I said, it's a non-invasive treatment. And as far as I am concerned, there is no long-term effect for that. However, this is something that needs to be, like I said, investigated in people with misophonia. Yeah. And I am not aware if this has been tested on individuals below the age of 18. And I'm pretty sure there is no research specifically on misophonia and people suffering from misophonia under the age of 18. That obviously needs to be investigated further.
Yeah, like you said, a lot more kind of understanding to be gained in that area. But today has been a fascinating insight into what we know at the moment and where it can possibly go from here. So we'll finish up our webinar for today. And please, like we both said, get in touch. We'd love to hear from you. And thank you for joining us today. Thank you very much.